Hello and welcome. My name is Keri Hager, and I am a pharmacist and faculty member at the University of Minnesota, based out of our Duluth campus. And as part of that, I practice as a pharmacist at our Center for Alcohol and Drug Treatment here in Duluth, working with folks who have substance use issues. And part of my role at the university is providing education about substance use disorders, including opioid use disorder and addiction, and how they're treated. And at one of my talks, Judy was there, and she thought some of the introduction that I give in my talk might be helpful to your group. So I hope you find that is the case. And certainly if you have additional follow-up questions, I'd be happy to connect with you directly by email or phone. So I'll make sure Judy has that information as well. So sorry I can't be there with you today. Hoping I can be engaging enough that you can take something away that's useful to you in your life and in your work. I do want to acknowledge several colleagues have contributed to this presentation over the years. We are funded by the Substance Abuse and Mental Health Services Administration for these educational outreach presentations. And I also want to just acknowledge all of you for your attention and engagement in this really important topic that's impacting our communities. Thanks. And with that, this graphic just is here to talk about like overdose death in the 3 waves. So opioids, or when I talk about opioids, it's an umbrella term that is for any opioid. So that can be a prescription medication, that can be an illicit substance on the street. So anything from a prescribed oxycodone or a Lortab to heroin or fentanyl. You may have heard of fentanyl illicitly manufactured on the street and sold as well. So opioids are sort of an umbrella term. And we started to see an increase in the early 2000s in opioid overdoses from prescription opioids. But as we cut back on the prescribing of those, we noticed a marked increase around 2010 in overdose deaths caused by heroin. And now more recently, about the past decade or a little less, we're seeing overdose deaths are actually being caused by other synthetic opioids like analogs of fentanyl or more potent opioids, not necessarily the kind prescribed, but those that may be manufactured illicitly that are very potent, very strong versions of opioids that put folks at higher risk of overdose and overdose death. And I just always want to remind ourselves that, you know, these numbers that we hear in the news and in our social media feeds, these are people, these are humans, these are brothers, sisters, children, neighbors. And it's really important to keep in mind the lives of these individuals and then all of those that are impacted by their health and perhaps their use or overdose. I want to talk about opioid use disorder a little bit more, or opioid addiction. You may hear that terminology as well. It's use of an opioid, and it could be a prescription opioid or other opioid from the street that is compulsive, dangerous, or both. And it is an illness and not a weakness or a moral failing, and it can affect anybody. And when we try to talk with folks about what is addiction, one way to sort of give a thumbnail sketch of what it is to think about the 3 C's. Think about addiction as a chronic, relapsing brain disease characterized by the 3 C's of craving, compulsive use, and use despite harmful consequences. So craving, like that drive to use, compulsive use, and use despite harmful consequences, sort of the 3 C's that describe what addiction is for folks. And really, addiction is a complex brain disease that I'm oversimplifying here. But when we think about how our brain works, we have sort of our reptile brain. That's the part of our brain that really is unconscious, that we don't control with our thoughts and beliefs. So that's the driving force that, you know, hunger, thirst, fight or flight, that comes from that reptile brain, that biologic part of the brain. Further out in the brain, we have the social, psychological, and spiritual cognitive portions of the brain. But when we're talking about addiction and opioid addiction, we're talking about that reptile brain that is, you know, hijacked, is one way to think about it, where your biological survival systems aren't functioning normally, and you have this abnormal drive that develops that you can't control with your thinking brain. So your reptile brain is hijacked, having these cravings, compulsive use, and use despite harmful consequences. Even if you're telling yourself, "Ooh, that was bad, don't want to do it," your brain is overriding that. And there really is not a simple cause. So when we think about addiction or substance use issues that folks have, there are multiple factors that come into play. So thinking about the host or the individual person, what's their genetic makeup? You know, how susceptible are they? to addiction, what's their environment, right? Are they surrounded by drug use? Has this been part of how they've grown up? Have they never even seen a drug? What's their social context? What are the resources that they have? What else might be going on in the environment that affects the individual is really important to consider, as well as the agent or the drug itself. So different types of drugs, alcohol, caffeine, tobacco, nicotine, opioids, they act differently in the body. And so some are more likely to cause a dependence, or more quickly the body adapts to it and needs it. So it really depends on the individual, the environment, and the drug itself. And it's really not a simple one size fits all cause or approach to treatment. So in addition to the 3 C's, we already talked about: the craving, the compulsive use, and the use despite harmful consequences. 2 other symptoms you'll notice with addiction are tolerance. So tolerance is when you need a higher dose. So maybe 10 milligrams worked before, but now you need 20 milligrams to get the same effect. So that's tolerance. And physical dependence. So that means that your body only functions normally in the presence of the substance, in this case, the opioid. And these 2 things in and of themselves do not make addiction. These are very expected. If people use opioids chronically, so let's say you have pain and you're using some hydrocodone or Lortab or something consistently over time, your body adapts to that such that you need that because you've become dependent on having it in your system to function normally. We expect that with chronic opioid use. So these 2 by themselves don't mean someone has an addiction, right? So I just want to clarify that as well, that you can have physical dependence to an opioid, but that doesn't necessarily mean you're addicted to because to be addicted, you have to have that, the cravings, the use despite harmful consequences, and the, of course, I'm forgetting the third right in the moment, compulsive. Thank you. Forgive me. All right. So when I find this is a really useful tool to explain addiction to clients, family, friends, you can write it on the back of a napkin when you're talking to someone. So on this graphic, we have on the y-axis how someone is feeling. So euphoric or high, happy, sort of okay, sad, or dysphoric or bad. And then as time goes by, it's here on the x-axis. So most folks that are healthy have sort of a normal variation in mood, right? You know, maybe you have your ups and downs in the day, but you kind of hover around that baseline, right? For most people with a healthy body. Now, intermittent use of an opioid in a non-susceptible person, right? So they get euphoria, they get high, maybe have a little bit of a hangover, a dip, and then they go about their life, their business, whatever. Another time they use again, get high, bump down a little bit, don't feel real great, but then get back to baseline, right? And they're able to use, they can stop their use. They're just using periodically to have that euphoria. However, if you have a susceptible brain and you're using over time, what happens is you get that high and that dip, but after ongoing use, the highs get lower and the dips get bigger. So this is your brain actually adapting to having that substance on board over time. So the highs get lower, the lows get higher or worse. And over time, people are feeling so bad without the substance, they're actually in withdrawal from the substance. So then they begin to use, not to get high, but just to function, to go to work, to take care of their kids, to do their day-to-day tasks. So they're using just to feel normal, because now their body is dependent on that opioid, that substance. And when people are in that withdrawal feeling, this feeling down here at the bottom right, what that feels like and how that's experienced is basically, I think about it as pain, anxiety, and all the fluids. So headache, you know, your eyes are running, your nose is running, you're vomiting, you have diarrhea, goosebumps, sweating, you're craving, feeling very irritable and restless. And it can be quite painful for folks as well. So what folks tell us is it feels really like they're sick, they feel scared, they feel like they're going to die, and their brain is telling them, remember, their reptile brain is hijacked and is telling them they're going to die if they don't use, because they've become dependent. So like I mentioned before, at that point, they're using just to get back to baseline and function. Their brain will not function without the substance. So they're using to get there. And do some people use to still get high? Of course. But at this point, people are just trying to not be in withdrawal, trying to function normally and get to baseline. And once you stop using opioids or other drugs, it takes a long time a long time for your brain to heal if it gets back to baseline at all, depending on substance and the length of use and the individual. So when someone quits using alcohol or methamphetamine or opioids, they're not going to feel, if they've used for a while, they're not going to feel great, right? For a while. We're not talking like days, we're talking like months and years to start to heal and recover from that. So I think that's important too when you're meeting with people. They're not going to quit and feel amazing, right? Not to mention the fact if when they were in their use, maybe they ran into some problems or trouble that now that they're potentially in recovery, they have to deal with. So I think that's important for people to know. And when you think about it, if you're feeling like, would you stop? You're having no enjoyment in life. You feel terrible if you're not using. You have this like compulsion to use that you can't control. It's a really automatic behavior. Your memory's poor, feeling emotional, impulsive, and vulnerable, and you really don't have other ways to cope. And like your life sucks. And you know, if you use, even if it's short term, and it's not going to last, you're going to have instant, reliable relief of all of that pain. All of that pain, all the different types of pain, whatever, are going to go away when you use, right? That's hard to stop. And especially when it's really hard to get in, if someone is ready or interested in getting into recovery or stopping use for a prolonged period of time, we put up a lot of barriers. It's hard for people. You have to have insurance, you have to have multiple assessments and transportation, and maybe you need to go inpatient or spend some time, like a month somewhere. And if you have kids or a job or other financial restrictions, that can be really hard for people to do. So just think about how challenging this is and how, would you stop if you were in that situation? And I really just want to reiterate that graphic one more time because I think it's really helpful, that over time with chronic use of an opioid, a body and brain become dependent on that substance and they're in withdrawal unless they have that substance to get back to baseline. So brain hijack, get the substance, brain can function again and manage the day. So I really want to emphasize this is very treatable for people. So medications for opioid use disorder, you may have heard medication assisted treatment, is the use of approved medications plus the counseling and behavioral therapies as a whole person approach for individuals with opioid use disorder. So when I'm talking about these medications for this presentation and getting folks out of that withdrawal back to baseline, I'm talking about methadone and buprenorphine or Suboxone are the two medications. There's a third medication that works differently that I'm not going to highlight as much here because it has less data for how effective it is. And so I just want to share, why do we use these medications? Like, isn't that just substituting one thing for another? Yes, it is. It's substituting a medication that we know the dose, we know it's pure, we know what it is, and we have a lot of data that it's very effective and much, much safer than what someone might get on the street. So what do we know about these medications? We know that our research shows that it reduces opioid use. It reduces overdose deaths. That's really big. It actually reduces criminal activity, right? So people aren't needing to get resources to get the drug that their brain is telling them they need. It reduces infectious disease transmission. This is really important. If people are injecting drugs or sharing equipment when they're using, you can spread bloodborne pathogens like HIV and hepatitis C. And so actually helping people by giving them medications for the opioid use disorder can reduce the amount of use, reduce the amount of infectious disease transmission, which affects people more broadly in the community as well. And then it saves money. There's actually a return on investment for society. If we're putting money into this, we're going to get a return into treatment of people. We get a savings to us as a community. Not to mention that positive impacts for the individuals affected, where they have improved social functioning, ability to participate in treatment, right? It's hard to expect someone who thinks they're dying and can't concentrate and focus and whose brain is telling them, use. It's hard to engage them in group mutual aid support meetings or counseling or therapy or other types of care if their body is telling them they're going to die if they can't use. And using these medications can help them stabilize, get back to that baseline, and then participate and engage. And so this is something you'll hear is referred to as a harm reduction strategy. Where would it be great if no one needed any medication for this? Yes, but we know this works better than no medication at all. By far, the data are really clear. So really, we're trying to minimize harmful effects rather than ignoring or condemning them, which we know has been completely ineffective. So it really is important to remember that opioid use disorder is not like a self-limiting choice or a moral failing or that you manage one time. It's kind of like diabetes, right? You don't get a diagnosis of diabetes, get handed some insulin, and head home and take care of it on your own without support, right? If you're not at goal, maybe you need to come in once a month and visit with a dietitian or your doctor, right? To check in, to make adjustments to your doses. Maybe you need some therapy or support because that's a challenging diagnosis to manage, right? So same thing for opioid use disorder. I think it's helpful to think about it as a chronic condition like that, or like high blood pressure or asthma, that it requires treatment and support over time and with different intensities depending on the individual's needs and the context that they're in. I think it's important to know it's treatable and it can happen to anyone, but it may require long-term treatment, just like other chronic conditions like diabetes. So again, why do we use medications? Get people back to baseline so they can function more safely and then engage and improve their quality of life. I do want to mention when I'm talking about medications for opioid use disorder, I'm not talking about naloxone or Narcan. That's a different, very critical and important medication. This is a medication that can be used to reverse an opioid overdose. When you get too much of an opioid, your breathing stops and then you can die. And so what Narcan does, or naloxone, which comes as an injectable or a spray in the nose, that actually reverses that. It kicks the opioid off the receptors in your body so that you can breathe again and be alive. And so it's a very different purpose and also very critical medication and tool that we can use to reduce harms of opioids and help give people a chance to get the support they need. So one myth I want to bust here is people are like, oh, that just enables people to use drugs, and that is not the case. There's no data to support that, and having Narcan available or not having it Narcan available does not impact an individual's on the whole their use. So I just want to dispel that myth as well. So naloxone, very important as well for opioid overdose reversal. So just want to mention that too. I just want us to pause for one moment and think about how do we contribute to stigma, because it is a huge reason why people don't come and get support or get treatment for their use disorders. There's so much shame. People have plenty of shame. We don't need to shame them. So how can we support people? And I think a big part of it is really know the facts about medications for opioid use disorder, know that it reduces death, know that it reduces crime, infectious disease, and saves money, all while helping the person live their best life. So I think we need to think about that and help educate others that may have a misunderstanding about this, and then support people so that they can get into recovery and get the support that they need. This is from the Institute for Healthcare Improvement, and I think this is very critical to how we combat stigma for folks. Is not only do we need to know the correct information and make sure we dispel any misinformation, but also we need to watch the language we use. We don't call people alcoholics and drunks and junkies or addicts, right? We call them people with substance use issues or use disorders, right? That person first language. We don't talk about them having a dirty UA. We try to use language that doesn't make people feel stigmatized and really focuses on recovery. So I think we can make a huge impact in our individual circles and spheres of influence by using language that is supportive of people rather than harmful. So I will provide the slides so you can get the email and my phone number here. I'm happy to answer any follow-up questions that you have. Again, I'm really sorry I couldn't be there with you today. I'm actually recording this during the blizzard up. I'm in rural northern Duluth, so glad I have power. Hope you're all well and look forward to hearing from anybody with any questions, and then would love your feedback. So Judy will have the link for you to fill out an evaluation for us so we can continue to improve. So thank you so much for your time.